our two presenters today. Our two presenters are Sarah Dansoa-Forda and Enoch Igumbu. And Sarah holds a master's in public health from the University of Ghana, as well as a bachelor's in information communication technology. She has worked as the head information officer at the district and metro levels for Ghana for 12 years and was appointed as the director of health services in 2019. She joined WHO as a volunteer data consultant on the Stop Transmission of Polio program in 2019. In addition, she acts as the focal person for the COVID-19 data management in the WHO country office for Namibia. And Enoch Igumbu is a field epidemiologist, also serves on the surveillance pillar of the COVID-19 response team. Enoch is in possession of a Bachelor's of Science degree in Environmental Health from the Polytechnic of Namibia and a Master's of Science degree in Environmental Science, specializing in water and health. Enoch has recently or lately worked for the Ministry of Defense and Veterans Affairs as the Chief Environmental Health Practitioner, responsible for heading the subdivisions of public hygiene, which entails environmental quality, food hygiene and safety, water sanitation, in addition to many other policy roles. Enoch is also subsequently being seconded to various government offices and ministries and agencies, including the Office of the Prime Minister, the Minister of Health, Social Sciences, as well as the Global Fund, especially during the emergency periods. So without further ado, I will turn it over to our panelists today to begin their presentation. As with the first presentation, please feel free to submit questions throughout the panel, and we will make sure to address them during the Q&A session. Thank you. Over to you.
Thank you so much, and happy to have you. I hope the screen can be seen. Emily?
We can see you. Thank you.
Thank you. So this is Sarah, as Emily has introduced, and I'm here with my co-presenter, Enoch, as she introduced as well. And we are presenting on data management, the Namibian way, or the Namibian story of data management. So our presentation outline will follow the overview of the outbreak in Namibia, the overview of data management, experience in data management tools, the achievements and lessons learned, and then the challenges and way forward. So this is just by way of making people who are not familiar with Namibia, to introduce them to the background of Namibia. So Namibia has a population of 2.5 million, and then it has 14 regions with 35 districts. Then Namibia is having 5 neighboring countries, which have all been affected by COVID-19. But the most affected is South Africa, who recorded highest case. And we have ports in the Irongo region, one of our regions, which is being used by countries. We heavily depend on goods and services from South Africa. This is to say that we have a large volume of truck movement between South Africa and Namibia. As at 30th September, COVID-19 cases that were recorded in Namibia, the total was 11,265. And all regions and districts in Namibia, that is the 14 regions and 35 districts, were affected with 2 regions having about 81% of the total cases. That is the Irongo region and then Commerce region. Commerce region is the regional capital, and Irongo region is where the coast is. The over 95% of these cases have no travel history. That is, in all the cases that we had, only 3.5 were imported from outside Namibia. And the case fatality as at the 30th stood at 1.1%. Then 4% out of the cases are health workers. So when we look at this epi curve that is being shown, we realize that after having our first case on the 14th of March, and then proceeding with 16 cases, we had a 45 days period of no cases recorded. That is from the 14th April to 29th May. And at that stage, we're at stage 1 of the outbreak, and there were lockdown all over the country. With the ease of lockdown measures, that we experienced exponential rise, and that is how the epi curve could be seen spiking along the line. But currently, as we speak, we are also in a moment where we are having reduced cases. Where does the data management sub-pillar stand in the response? The data management sub-pillar is a subset of the surveillance pillar in Namibia. That is, we are initially supposed to manage data from the surveillance pillar. However, we also coordinate data management from the other pillars, like case management pillar, point of entry pillar, and other pillars. What are the tools that we are using in Namibia? Initially, like I said, the cases started in the capital. And so the EOC at the national capital was activated with data management, with people from all levels and all organizations, from UN, from CDC, and from various organizations like the National Statistical Authority. Paper-based tools were used for collecting data at the lower levels. That is the case investigation forms and the laboratory contact tracing tools. Among all others, we used the paper-based. So people at the lower level and in the facilities will collect data on the papers, and it will be entered into line lists, various line lists that we had. Case management line lists, suspected case line list, mortality line list, health worker line list, among various line lists. But along the line, when after the first phase, we began to experience many cases being recorded in the Irongo region, we realized that the line list cannot be enough because it was tedious looking at the least number of human resources that we had. So we planned on moving on to DHIS. And as part of our migration plan, because we already had so many data that had been entered into the line list, and we had few people to enter into the DHIS, we decided to let the district stop entering in the line list while the national level still enters in the line list. So for the prospective data, the districts were supposed to enter it into the DHIS. Then for the retrospective data, we planned on hiring people to enter it into the DHIS. But in order not to short some form of information for analysis, we decided to keep the line list being managed at the national level for analysis. So this line list is generally analyzed at the national level because we don't have much capacity at the district level to do analysis. So what happens to this analysis that we do? Is it being used for this response? The answer is yes. And you can see from what I'm showing that the data that was analyzed was the same data that was used for the CTREP situational report that was used for decision making at the higher level and in the district. It was also used for partner support. For example, partners have provided money for training, like CDC provided a lot of money for training, WHO provided us with human resource, and UNFP and other partners provided because of the data that we provided, looking at the gap. We also use this same analysis to inform the stages that we move to. Is it ready that we move to the next stage? This was all informed by the data. And we also use it to update the protocols, surveillance protocols and other points of entry protocols. It guided our training needs. For instance, when we realized that health workers are infected, there was the need for infection prevention training, and all came from this analysis. So this is just by way of showing some of the information sharing mechanisms. This is the snapshot of the situational report that is being disseminated to various headquarters. This is also a situational dashboard available to the public to know what is happening in the COVID-19 cases, the deaths, the recoveries, and all of that, because people do call in a lot. They want to know what is happening. So we instituted this one with the help of the National Statistical Authority, and it's accessible to the public and is being updated every day. We also have a dashboard for the call center, and this was done by a private institution, IT, which also offered itself freely to help in the COVID situation. So this is what goes on at the call center, the calls per day, and what people are calling for. And then this is the launch of the dashboard and the call center, which is also found. So this is the setup of the call center. And the other picture to my right is the launch of the COVID-19 situational dashboard, which was hugely organized. At this moment, I will hand over to my co-presenter, Enoch, to take us through the next lesson.
Okay, good afternoon, everyone. As I was already introduced, my name is Enoch, and I'm just going to take over from Ms. Sarah. I'm going to continue with the experience in the data management tools. So as he have alluded earlier that we are migrating, or we had a migration plan to DHIS2. So on the DHIS2, we have DHIS2 tracker and DHIS2 instant aggregate module, whereby in the tracker module, we are capturing information on case registrations, on laboratory data captures, on case management. As for the aggregate modules, we are capturing information on contact tracing, point of entry, whereby also we are having a mobile app which is being used to capture the truck driver information at point of entry. So we have the iMarketing electronic solution, as my colleague have alluded to, that the call center data are being recorded, or they are being reported in this platform. And for the health worker portals as well, this is an app that was developed by the Namibian University of Science and Technology, whereby the people in quarantines are self-reporting to the healthcare workers through this app. The achievements and lesson learned. We have developed a data management plan and a guideline, which when we started off, actually, we did not have some of these tools in place, but through the journey, we realized there was a need for the data management plan and a guideline that could guide the data collection, the data flow, data quality as well as the data analysis. So that's was one of the milestones. So we have as well customized the DHIS2 COVID-19 tracker modules that I've just spoke about earlier. So, and we also developed the mobile app for the point of entry data, specifically for the truck drivers. And we have trained a number of, or all the district health HIS officers and surveillance officers so that they can start to enter their data into DHIS to stop from entering into the line list, the Excel database. And then we have created a COVID-19 situation dashboard for the general public, which Sarah was just showing you the pictures at the inauguration or at the launch of that. So we have as well developed the hotline call center data management system and the dashboard that was with the assistance of the iMarketing, which is a private IT firms. We had a very good intersectoral collaboration with both the different organizations such as NSA, which is the Namibian Statistics Agency, the private IT firms, the HISP Namibia, which is the Health Information System program that help us with developing or the customizations of the DHIS tools, as well as with the universities that help us with the development of most of the apps. We also had a very good collaboration with the partners, the UN organization partners, the WHO, UNICEF, UNAID, and UNFPA, as well as CDC. So these, in most cases, they provide either technical assistance or technical capacities as well as the funds. We had a staff complement of about 37 people, and there was also funding for the training, and there was some donations that were given in form of tablets and laptops that were being used by the data clerks. So despite those achievements, we also have a number of challenges, and we kind of derived the way forward on those challenges. Our number one challenge is our huge data backlog. So as the previous presenter have alluded to, that we do not have enough human resources capacity to be dealing with a data backlog or to be dealing with daily data entry. So this have been piling up, and then we realize, or we find ourselves with a data backlog that was not entered into the DHIS2. So as a way forward, we have hired temporal data clerks to clear the backlog, and the CDC was provide the financial resources. We had a lot of paper-based data collection tools, which did not augur well, and that's why we thought of now migrating to DHIS. And then we, as a way forward, we plan to use GoData, but there's already plans underway for us to get assistance from WHO Afro for us to roll out the GoData application that can be used for data collection as well as capacity building on data management. We had non-availability of data flow protocols and data management standards. So this means that from the beginning, we do not have all the needed or the necessary protocol that could guide the response plan in terms of data management. Therefore, we had no data management standard as to the tools, how often should we revise the tools, and as the outbreak was progressing and we're moving into different stages, so there have been many changes in the response mechanisms, and this one kind of hampers or was presented as a challenge. So the way forward to that, we, as data management, we developed the protocol, and then we are awaiting the approval and the dissemination of such protocols. In terms of data quality, in terms of data analysis, as well as data analysis plan, yeah. The poor coordination of data management process and systems. So at some points, we did not have well articulated or defined processes and systems, and that led to kind of poor coordination, especially between the national levels and the districts or the peripheries. Most of the data are being born at the very periphery levels, either at a community level or health facility levels, and then by the time they reach at the national level, they either are not properly coordinated or are either distorted. So as a way forward, we kind of trained a focal person that were assigned to each pillars, and then we institute inter-pillar data management meetings. So what we've been doing, we've been having calls so that we capacitate the regions and the districts, and just to ensure that they are doing the right thing. DHIS2 functionality challenge. We had a challenge with the DHIS2 system of COVID module tracker, especially the reporting function narrative, which was not really helping us to do the proper analysis that we wanted to do. And then we engaged the developers of the DHIS2 were tasked to address the challenges, and they're busy working on it. That's HISP Namibia, Health Information System Program Namibia, with the help of HISP South Africa. We had issues of interoperabilities of apps. As I've mentioned, we had a number of apps. One of it is a self-reporting health portal app, and we also had an app for iMarketing. So these apps are not interoperable to DHIS, which is our kind of the main system that we are using to collate all the data, so that it can be easier for us to do the analysis. So as a way forward on this, we also tasked the developers to address this challenge. We also had a lack of data management sub-pillar at the regional level. The way the response team is structured in Namibia is that we have a number of pillars at the national level, but those pillars that we have at the national level are not well cascaded down to the district level, especially when it comes to the data management, which is more critical and supposed to serve as a backbone. Now, as a way forward, we are busy building capacities of other cadres and staff to constitute the data management sub-pillars at the district level. So what we are doing, we have those focal persons that were kind of identified to play the role of the data management at a district level. This is a picture of data backlogs. So this, in the picture, it's a piles and piles of case investigation forms that we use as our primary data source. So as we are saying, most of our tools were paper-based, and we could not enter or translate these paper-based tools into the electronic versions, and that resulted into a backlog. That is, we organized now a team which is busy working on this backlog, as I noted earlier. And that marks the end of the presentations. The questions are more than welcome.
Thank you both Henok and Sarah for that wonderful presentation. We've had quite a lively discussion in the Q&A. A lot of our colleagues who are participating have lots of questions for you, and a lot of the efforts and success that you have had. One thing that you just noted, which I'll pick up on, which was a theme of the questions, you talked about challenges with the data backlog. I think some of our colleagues were wondering if you could describe a little bit more about how the data entry is managed and potentially, the numbers of individuals who are working on this data management and how that's increased during the response. I think either Sarah or Henok, either one, if you take that one.
Okay, if I
think you are on mute, so if you want to unmute yourself, we'll be able to hear you all. Just one moment. I think our colleagues in Namibia.
Okay, sorry for that.
Okay.
All right, sorry for that. What happened is the data entry was taking place at a national level, even though it was supposed to be done at a district level. When we started, the district did not have capacity in terms of the HR or the human resources, as well as the technology that could be used for data entry. So all the data entry was done at a national level. And when we started with few cases. So we had a few cadres that were working on that. We had about maybe one person working at one line list. So we had a number of line lists, as Sarah was alluding earlier on. But specifically on what we call a suspected line list, whereby everybody who is tested is supposed to form part of that line list. So as time goes on, we realize as the cases were increasing, we kept on increasing that number of the data clerk. And then as we speak, they are standing at 37 in total. And that's how the backlog actually resulted. So they couldn't catch up with the daily people that were being tested to enter the daily case investigation forms.
And then to also add on, the backlog also came about, again, because we're also migrating into DHIS. Then we all know that in DHIS, there wasn't a way to import the line list that we already had into DHIS. So all that was entered into the line list are supposed to be re-entered into DHIS. And the cases also kept increasing. So while we're catching up with the increase, we also have to go back for the backlog. So that is how it came about, migrating from line list and the manuals into the DHIS created the backlog. Thank you.
Great, thank you. And I know we have many questions that are coming in. And one thing I will also encourage, just for everyone's awareness, all the participants, is we will also be engaging on the Discord platform, so we can hopefully address some of the more specific questions about tools themselves and information sharing. Another sort of theme that we had in the questions is about sort of the data tools, how they talk to one another. And there was a question about whether the tools that you're using are able to sort of talk to others at the national level from the district, as well as with potentially with external entities such as WHO or otherwise. Can you describe sort of the between and the communication between these platforms, if any?
Thank you for the question. Yes, to the largest extent, the tools do talk to each other. We have the case investigation forms as the basic data collection tool at the facility for suspected cases. And then once that suspected cases is entered into the suspected case line list, the data from the line list is extracted into the confirmed case line list. But initially, there wasn't this coordination. This data was also entered all over again by the case management team into another confirmed line list. But as way forward, we kind of made the suspected case became the basic line list where we extract to the case management line list, even though there are gaps. So after the case management line list, which is also almost same as the confirmed line list, we use this for analysis into the CITRIP. So one line list feeds into the other. For instance, the contact tracing line list feeds into the suspected case line list when the case tests positive. So once one ends, the next starts. So that is how the line list feeds into the other. Thank you, Enoch. I don't know if Enoch will add on.
Great, thank you. And we had a specific question I'm hoping maybe you can address and clarify for all of the participants. They were asking in terms of the DHI S2 platform itself, whether this only exists sort of in mobile or is it desktop as well, or both, and what that looks like for those who've never used that before.
Okay, thank you for the question. For what is being used in Namibia, we have a mobile app for the point of entry, and this was developed by the HIPS that Enoch alluded to. So we have a mobile app that is being used at the point of entry. But for the various data elements like case management and others, it's being entered on the laptop, but it can't be available also on the app. But due to inadequate resources of tablets, of phones to enter, we just sorted to the laptop, which is being entered mostly at the national and district and regional level. Thank you.
Great, thank you.
I don't know if I've answered rightly.
I think so. We have many questions. You know, specifically, I think participants who may not have used that type of tracker before, you know, are trying to see, you know, best practices and learn from your experiences. So thank you. It's definitely helpful. There's a couple other questions, and maybe I'll quickly summarize. You've both described some of the challenges as well as some of the successes that you've had in, you know, shifting to these new information system sharing and you know, some of the backlog in terms of timeliness of reporting and being able to have staff at the district levels. Are there any other sort of key, either both, you know, things that have gone well, successes, or other challenges that you would like to highlight that may benefit all of the participants who are having, maybe facing similar challenges in their respective countries?
Okay, in the question of whether there's some more kind of challenges and success stories. The success stories, let me start with the success story. Of course, we, as I've alluded, that we had a very good collaboration and intersectoral kind of collaboration with different partners and organizations and different government sectors. We had a number of skill sets that came together, which it's a very good achievement to me, since it was the first time we are experiencing an outbreak of this magnitude, and we really didn't have all the adequate information that we could guide us on how to do the response. So we also had a challenge of say coordination, resources, and also the especially when it comes to the technology as well as the human resources. But then we kind of managed to, through hiring temporal temporal data clerks and temporal people that came to help us.
And then one thing I would also like to add is that most of the resources at the human resource that is being used at the national level are external, from UN, from CDC, from National Statistical Agency. So what it means that once this outbreaks go down and all these people pull out, there will be a very huge gap. So that is one other big challenge that the country is having. Thank you.
Great, thank you both. And for the sake of time, I know that we've had many questions that have been brought up in the Q&A session. Thank you to both Sarah and Henok for your wonderful presentation. I know that I have learned a lot, and I know that I imagine the participants have as well. So thank you to both of you.